I'm now pleased to welcome Professor Laura Lee McIntyre. She's a professor and co-director of the School Psychology program at the University of Oregon and Associate Director of the Child and Family Center in the Prevention Science Institute at the University of Oregon. Over the past 15 years, she has worked in the areas of prevention and early intervention of behavioral and mental health problems in children with developmental disabilities. Her research has been funded by the National Institutes of Health and the U.S. Department of Education and emphasizes working with families, schools, and healthcare systems to promote positive outcomes for children with developmental disabilities and their families. And I think I'm going to introduce you in Norwegian as well. Må jeg puste litt, for det var ganske slitsomt. Laura Lee McIntyre er professor og co-director, det klarte jeg ikke helt å oversette, på programmet for pedagogisk psykologi ved Universitetet i Oregon og associate director på The Child and Family Center in the Prevention Science Institute ved Universitetet i Oregon. I løpet av de siste 15 årene så har hun jobbet innen forebygging og tidlig intervensjon av atferd og psykiske problemer hos barn med utviklingshemning. Forskningen hennes har vært finansiert av The National Institutes of Health and US Department of Education og legger vekt på arbeid med familier, skoler og helsevesen for å fremme positive resultater for barn med utviklingshemning og deres familier. Welcome. You had the long travel and we're so delighted to have you here with us today.
Thank you so much. Can everybody hear me? Unfortunately, I will not be presenting in Norwegian. I can't go back and forth as easily as Torin. But thank you for that warm welcome. It's beautiful. It's lovely to be here. This is my first time to Norway and indeed my first time to Scandinavia. I'm a little jet-lagged, so hopefully people can smile along and encourage me if I nod off or doze off, because it's in the middle of the night at home. But it's just a pleasure to be here. So I'm giving two different presentations. One right before lunch, hopefully it won't make you ill and you can eat, and then one right after lunch, and hopefully you'll be alert right after lunch and not go into that, dozy slump that we often feel right after lunch. So you have a little bit of a Laura Lee McIntyre sandwich there with lunch before and then after. The two parts of my presentation will be one focused primarily on research, and we'll start out with that. So get your cups of coffee ready. We can be very alert as we focus on research. And then after lunch, we'll talk more about the applied aspects of actually implementing a Webster-Stratton Incredible Years parent education session, what it looks like, some of the modifications that my team and I have been working on in really making this a bit more meaningful for families who have children with developmental disabilities and other special education needs. So part one is a little bit more research, part two is a little bit more applied, but all of my applied work is informed by research, and all of my work as a clinician is really informed by the families that I serve. So hopefully it will all come together. Okay, let's see if this works. Test number one. It works. Great. So this is what I just said, overview. And I think you've heard from the speakers earlier this morning that children with developmental disabilities, and in my slides you'll see that I've abbreviated that DD, and I know that there's different terminology that we use in different countries and so on, but I'm thinking here very generally speaking, children with some special support needs. In my research, I've primarily focused on children that have some developmental delay, maybe a specific diagnosis, but I'm actually less concerned about what that actual diagnosis is and more concerned about how to support them. So the diagnosis and the actual etiology or cause of the disorder is important, but not as much in my own research and practice as what to do about it and how to support those children and families and the communities in which they live. So we'll talk about this group of children being at particular risk, thinking a little bit about what that means in terms of family impact and how to support families, particularly parents, although I'm fascinated by the work that some of you are working on in terms of supporting siblings and the whole family unit. So certainly we can have conversations about that. And don't be shy if you have questions in Norwegian or in English. Please ask those. I'd love to be engaged in a conversation if possible. And then I'll talk a bit about some of my research with the Webster-Stratton Incredible Years. Now, why are we focusing on this group of individuals? Well, my life's passion, besides my own family, of course, is really thinking about how to support those that might be most vulnerable in our society. And children with developmental delays and disabilities represent one group of vulnerable populations. There are many, many children with developmental disabilities. Worldwide, we see 1 to 3% of the population, depending on how you classify, depending on what instruments you use. So there's a good number, even though we would still consider this to be low incident or rare, there's a good number. And between 1/3 and 1/2 of these children may also experience heightened behavioral or mental health problems, whether or not it's diagnosable by DSM or ICD taxonomy, whether or not they have a diagnosed psychiatric disorder. We do see that many of them, a full 1/3 to 1/2, also experience significant behavioral or mental health support needs. So we're talking about a lot of kids. We don't always know what causes this heightened risk or propensity for mental health problems, but we do have some clues, and I wonder, great, this works. Children with developmental disabilities might have additional medical needs or concomitant, combined medical problems. Physical disabilities, maybe sensory impairments, deafness, blindness, other sensory impairments that make them more vulnerable or more susceptible to mental health or psychiatric problems, given their additional needs, support needs. And we know that the behavior as well as the developmental support needs really place a great impact, oftentimes, unfortunately, negative impact on the individual, him or herself, as a child, an adolescent, certainly as they grow up into adults, but also on the communities that support the individual. And my work has primarily focused on early childhood. So parents, how many parents are out in the audience? How many parents? So we all know that a parent's job is 24/7, all the time. You can't call in sick if you're a parent. In fact, I'm pretty sure that moms and dads can't ever get sick, because then, of course, who will take care of the child? Disclosure, I have a 1-year-old and a 3-year-old, and they're at home with dad right now, hopefully sleeping peacefully. One can only hope. So we know that families that care for and parents that care for children may be impacted by a child's behavior and their developmental support needs. In the United States, and I imagine in other countries, there's a great deal of stress on the government to support individuals throughout the lifespan in terms of independent living, job coaching, community housing, and so on. When there is a combined behavior problem, in addition to the developmental or cognitive support needs, they can tax the system. This graph, I apologize, got cut off here, but this should say mothers, child behavior checklist, behavior problem scores. The child behavior checklist you may be familiar with if you're a clinician or a researcher. It's a 100-item checklist where parents, mothers and fathers, report on the number of behavior problems that their children are having. It's used worldwide. It's often used in research, but it can be used in clinical practice. These graphs in the green show children with developmental delays, and in the yellow, we see children without developmental delays, so typically developing children. And here, mothers are reporting for, in all instances, externalizing behavior problems, things like aggression, disruptive behavior, internalizing behavior, things like anxiety and depression, and then total mothers are reporting more behavior problems and mental health problems for children who have developmental delays versus our typically developing children. This is from about 200 children in a larger study that we're conducting, looking at parents' responses and coping skills and family support needs when they have young children with developmental delays. Incidentally, these elevated scores are in 3-year-olds. So a lot of the work in mental health, more epidemiological studies, have really focused on adolescents or adults as being at heightened risk for psychiatric or behavior problems. And in some of the work that my colleagues and I have conducted, we've noted that in 3-year-olds, children with developmental delays have 3 times the number of behavior problems than their typically developing counterparts. So this is not something that starts in adolescence. This is not something that starts in adulthood. We're seeing this with little itty-bitty children, 2 and 3-year-old boys and girls already demonstrating heightened behavior problems. So we know that young children are even at risk, and left untreated without necessary supports, we're really looking at maybe development of a severe behavior disorder or mental illness, potentially over the lifespan. So the focus of my research is really early intervention and ideally prevention of psychiatric problems or mental health problems when possible. Really quickly, this is a busy slide with a lot of words. Really quickly, we've identified that young children as young as 3 have heightened behavior problems. When they're 5 and they're transitioning into kindergarten in the United States, the same sample showed elevated behavior problems as reported by teachers. So it's not just moms and dads are reporting behavior problems. Teachers at school are reporting more behavior problems. We have more children in the developmental delay group meeting criteria for clinical problems. Student-teacher relationships are impaired. I'm fascinated by this notion of student-teacher relationships and, of course, parent-child relationships being a buffer for protecting children against negative impacts, but also certainly thinking about a student-teacher or a parent-child attachment as being something that's at risk or potentially something that's more vulnerable. So if parents and teachers are taxed or stressed and the relationships suffer, what does that mean for children and supporting children in those natural environments, home or school? So again, this is just another slide that demonstrates that this very young sample, 3, 4, and 5-year-old children with developmental delays are more vulnerable, more susceptible for problem behavior at home and school settings. In terms of parents, we know that parents are reporting just their own wellness, psychological distress, heightened depression. And again, I want to be very careful to not suggest that raising a son or daughter with a developmental delay causes depression. I'm not saying that at all. In fact, I've worked with hundreds of resilient, wonderful parents who have coping mechanisms and social support structures and a family network and a network of professionals that allows them to function quite well. So I'm not suggesting that if you have a child with a disability, then you are doomed. That's not at all what I'm saying. What I'm saying is that many parents who have children that are more difficult to care for, given their support needs, given their behavior needs, given their cognitive and developmental needs, many of these parents are reporting that they're experiencing heightened depressive symptomatology and are more vulnerable to mental health problems themselves. So if you think about a parent who is struggling with their own mental health and mental wellness and caring for someone that's more challenging, parents themselves could be the point of intervention. We could develop interventions focused on parents' mental health and well-being. And in my research, and of course the research of Webster-Stratton, we focus on parents as a means to support children, but there's also an opportunity to support parents as a means to supporting parents' mental health and well-being. So I think there's possibly at least 2 different means of intervention, one focusing on the children, one focusing on the parents. And of course, when done well, the whole family system would benefit. This graph here shows parents' reports, so both mothers and fathers. This is the same sample of about 200 children of 3, 4, and 5-year-olds. Mothers and fathers report on a scale that measures the negative impact of the child on the family. This scale, incidentally, also measures the positive impact of the child on the family. So we're not just focusing on the bad and the negative. And we have some really nice data suggesting that in some instances, parents may report a more positive impact by virtue of having a son or daughter with a disability. So I don't mean to get up here and psychopathologize everyone and saying, oh, we're all doomed and gloomed, but these data do suggest that both mothers and fathers report more negative impact when there is a child with a developmental delay in comparison to when there is a child without a developmental delay. And these sample sizes are about 100 each. So again, when you're looking at more rare disorders, having a sample size of even 30 or 40 or 50, 100, 200 is something that we get really excited about. Because as the researchers and clinicians in the audience know, it's really difficult to get a large sample that's representative. And we're pleased that we were able to include over 200 families in this particular sample. Interestingly, so if you were to just look at this slide, you might think, well, gosh, moms and dads with children with developmental delays report more negative impact. It must be something about the developmental delay that is related to the negative impact. And when we delved a little bit deeper, we noted that in both groups, both the group of children with developmental delay and in the children without developmental delay, the impact, the negative impact, was fully explained by the presence of behavior problems, such that in the typically developing kids without delays, moms and dads who had children with high behavior problems, BP, high behavior problems, report more negative impact. And children without delays with no or low behavior problems report low negative impact. Same for the group of children with developmental delays. So it's not so much a function of developmental delay status per se, it's a function of the behavior problems. And so that's a really important feature or variable for us to keep in mind, that it's not just the developmental delay that might be taxing, it's the presence of a comorbid or additional behavior problem. And so these are some of my earlier studies conducted in the early 2000s. And I consider this work to be really important, but it's sort of like we're admiring the problem. Like, boy, this is a problem. Children with developmental delays or children who are typically developing who have behavior problems negatively impact their families. To me, that's sort of a no duh. Do you have that expression here? That's sort of obvious. And that's a finding that my research team and I sort of talk about as admiring the problem. Like, oh, Houston, we have a problem here. But what do we do about it? So we can see that behavior problems are taxing, but what do we actually do in terms of early intervention and prevention? So what do we do? What have I done? Mind you, when I was in graduate school and getting my PhD, I did a lot of studies that admired the problem. Longitudinal studies following children over time, following parents over time. But it wasn't until my first job as an assistant professor, my first faculty position 12 years ago, that I really started to take a look at intervention and early intervention programs. So for all of you who are in the trenches working with children and families, or parents maybe supporting your own sons and daughters, hopefully this message resonates with you. So I started looking at the research in parent education and parent training. And for those of you that are familiar with this research, you know that Carolyn Webster-Stratton's work is really important and has had a huge impact on the field. She started out in 1982 working on the Incredible Years program when she was working on her own dissertation. And so this work that she has developed over many decades was born out of her own research for her dissertation. And she has developed parent education, parent training programs that have been used with a variety of populations. So when I was sitting back and scratching my head thinking about what intervention program I would adopt, I thought, well, gosh, I'm not that smart to develop my own intervention program. I'm going to look to the literature. I can't reinvent the wheel. There must be something out there that's evidence-based, that's well-respected. And my thinking here was that children with developmental delays and disabilities often experience behavior problems that are very similar to those experienced by other children with conduct problems, oppositional problems, non-compliance, problems listening and following directions. So there's nothing that's special or unique in terms of behavior problems for our children with developmental delays and disabilities. That's true to a point. Of course, it's complicated when there's genetic vulnerabilities, propensity to engage in certain behavior problems over others. But generally speaking, children with developmental delays and disabilities experience similar behavior problems as other children. And so thinking about how to intervene, I wanted to look at what had been used for the typical population of children with behavior problems. So into the literature, I found Carolyn Webster-Stratton's program. I was familiar with it, but never had I used it. Parent training as an intervention approach has been used for decades with children with disabilities, and in a parallel line has been used for decades with children with conduct disorder and other behavior problems. But it hasn't been until recently that parent training intervention strategies for children with conduct problems have been adapted and modified and tailored for use with children with developmental disabilities. And so that's something that has been a common theme in my own research. So for those of you that don't know, we'll talk about Webster-Stratton's program after lunch. So this is just a little preview. It's evidence-based. It has been identified in the United States by the American Psychological Association as a well-established psychosocial treatment. And being well-established means something. It's based on a bunch of research methodology, effect sizes, and other criteria. So the bottom line is it's pretty good. It's been used in a lot of studies. It's been demonstrated to be well-established as a treatment. When I originally adopted the Webster-Stratton program for use with children with developmental delays, I did what most researchers did. I ran a small pilot study to make sure that the approach that I was taking was suitable, it was acceptable, parents liked it. I got some initial pilot data. I used a very simple, if anyone in the audience is a graduate student working on a master's or a PhD, don't do what I did. I used a single group pre-test, post-test design. There's nothing wrong with that. Just to establish sort of, does this work? Does it have clinical utility? I was happy that a journal published it because there's all sorts of problems with the design. But bottom line was it was perfect for my needs in establishing whether or not this was even feasible, whether or not I was on the right track. And so there's a reason why we use these designs, of course. I'm looking at Krista because we had a nice talk about this last night at dinner. Well, he ate dinner. I just drank wine and had dessert. Shame on me. So the Incredible Years program really is quite simple. It focuses on content that I would consider to be just good parenting. So we're working with families to teach very evidence-based, research-based strategies that promote positive child developmental outcomes. And I'll go into a little bit more detail after lunch about what this intervention looks like. So right now I'm just giving the overview. We used a 12-week group format. Running groups is hard, as folks know. Running groups is challenging. We met in community settings. I'll tell you much more about what we did, how we did it, what I wish I would have done differently, what we're doing now. 2.5 hours per week. The bulk of the content focused on discussion of key topics. We used videotape vignettes, so we showed short videos, we discussed, we did some role play. So this is with the parents. The children were supported in another group, basically a daycare with some structure to it. But the focus of the intervention is really on parents and supporting parents in their role in supporting their sons and daughters. Role play, modeling, so demonstrating the procedures, providing feedback. Didactics, so formal teaching, was used in about 10% of each class. So it was much more discussion focused to really engage parents with where they were at, rather than, no PowerPoint slides, no lecture, no fancy, technology. It was just really discussions and some video. And the curriculum we'll go into after lunch, but really focuses on play, developmentally appropriate play, the importance of play. Lots of parents that I've talked to get really bogged down by teaching their children with developmental disabilities and finding every opportunity to teach or work on a learning goal. And in this program, what I love about it is it gives parents room in their day to just play. And of course, we know that through play, we can teach a whole bunch of different things, that it doesn't have to be so structured. It doesn't have to be at the table. There doesn't need to be a point in terms of a learning goal, that just establishing and creating that positive relationship can go a long way in both preventing problem behaviors from occurring, but also boosting that relationship and that attachment. So the intervention really focuses first on play, using positive praise, rewards. It's very behavioral. So there's a focus on positive reinforcement, a focus on rewarding behavior that you want to see more of, and not rewarding behavior that you want to see less of. It's a very simple formula. Limit setting, so, and I'll go into this a little bit more later, using appropriate commands and instructions to increase compliance. And there's ways that parents and other caregivers can give a good command that is more likely to result in listening and compliant behavior, and ways that we can screw it up. And with my own family, having kids changes everything. I was a parent researcher before I had children. Then I had children, and I thought, oh my God, now I really know. So it's given me a different perspective. But there's lots of things that we can do to screw it up. And here, the focus on limit setting and giving appropriate commands and instructions is really useful, very practical material for parents. And I've found that this limit setting module in the curriculum is extremely helpful. It's probably my favorite, in addition to play. And then, of course, this handling misbehavior and problem solving is important as well. The structure of the session, so there's 12 weekly sessions, the structure is such that you talk about play and praise and rewards first, and then dealing with challenging behaviors last. And the idea here is that if you use a lot of positive up front, the need to use more behavior management plans and handling misbehavior is reduced, because you have more positive interactions, you're establishing more positive attachments and relationships. There will be less of a need to intervene on those challenging behaviors. You won't be able to eliminate, most likely, all of the challenging behaviors. So this material is important, but you start here because it gives you a good prevention or early intervention strategy. Okay, I'm going to just go over this very quickly. Major findings from my pilot work. So this was the small study. We established that parents like this, that they report high levels of satisfaction. And that's good because we modified the curriculum a bit, and I'll tell you more about that later. We modified the curriculum. Parents showed up. They liked it. They reported that it was useful. And we saw some reductions in parent behavior, negative parent behavior that we wanted to reduce. And we saw some reductions in negative child behavior. So we collected videotaped parent-child interactions of them playing together in structured tasks and in free play tasks. and we're looking at what parents were actually doing and what children were actually doing, as well as the paper pencil questionnaires and reports that parents filled out. I like this finding. We also saw an increase in parents' reports of the positive impact of their child on the family. So we're reducing more, bad things, problems, and we also saw an increase in some positive impact. That was from the pilot study. Then I was funded by a grant from the National Institute of Health, and so we were able to include a control group. And of course, having a control group gives you a little bit more confidence that your intervention is actually working. Most parents that show up to groups are very motivated and engaged and have a high degree of wanting to please you. They also know that they're participating in research, and so sometimes they try to act good or, get better because they're invested in participating in the research. And that's great. And as a researcher, I love that because we oftentimes have very compliant, very willing parents. Including a control group gives you a reality check because you're able to sort of track the progress that would naturally occur over time in a very similar group of parents who are motivated, who are participating in research, and that want to please you. So this was a little bit more of a rigorous test. We asked 2 questions for this study. We asked a lot of questions, but 2 main questions. The first is, does the Incredible Years Parent Training, the Webster-Stratton program, with the modifications that I've made, was it more efficacious than the usual care control group? So let me just say a word quickly about the usual care control group. All of these children were between 3 and 5 years of age, receiving specialized services in the community and at school. So this was not a group of children that was not receiving services. Their families were receiving services and the children were receiving services. And they were all receiving services that were deemed by multidisciplinary teams of professionals as appropriate. So it's a bit more of a rigorous test. You're looking at really a treatment group in comparison to your experimental treatment group. So you've got your, business as usual group, all receiving care, all receiving services, and you're comparing it to a group of children and parents who are receiving your, experimental intervention. The primary outcome variable that we were looking at in terms of reducing these inappropriate parent behaviors was the parent interaction observation that I'll go over very quickly. So, of course, we were interested in reducing children's problem behavior, but initially we wanted to see if the parent-child interaction changed. So it was established that the parent-child interaction was related to the child's problem behavior, and that's part of the theoretical model and part of the scientific rationale for why you would focus on parents primarily, even if you're interested in child outcomes. So very, very briefly, I realize I have more slides than I have time. We developed an observational code that focused on these behaviors. We collected 15 minutes of parent-child interactions in the family home. So it was in a natural environment. The interventions were completed in the community, in a community daycare or preschool setting. So nobody came to the university, nobody came to a research lab, nobody came to a facility. We were in the natural environments, which is a strength, but also a challenge, for folks that are doing this type of research. We recruited families that were involved in early intervention and early childhood special education preschool programs. We screened them. They met some initial eligibility criteria. We randomized half of the families to receive our experimental treatment, which was 12 weeks of our parent training, plus they had their usual care, specialized preschool programs, family services. And then we had a control group. Upon completion of the 12-week intervention, all of the families that were in the control group were offered the parent group's should they wish to be involved in the parent groups. And all but 3 actually participated in the parent groups. And we had 2 time points of assessment. So it was still a pre and post, but we had a control group. Just really quickly to tell you a bit about the families. This was all conducted actually in New York State. Children were about 4 and a half, for about 3 years of age. Sorry, these are parent data. Parents were about 35 years of age. Primary caregivers were mostly mothers. Less than half were working. So again, suggesting that raising a child who's very young with a disability might require more time at home. And indeed, we had parents report that they would have gone back to work, but given their child's ongoing support needs, they chose to stay at home. Pretty well educated group, some college. These numbers, the CESD measure, that's a measure of depression. So we had in both the treatment and control groups, 42%, so almost half of mothers reporting heightened depression scores. So again, that's sort of something to think about if you're working with families and working to treat the children. We need to be more cognizant, more aware of also supporting maybe the mental health needs of parents. Family income was pretty low, and about 1/3 to 1/2 were receiving government assistance, financial assistance. In terms of the child characteristics, they were about 4 years old, most of them boys. Again, we see about 2/3 of children, early childhood populations with developmental disabilities as being male, boys, so that's not surprising. Most European American, about 1/4 to 1/2 of our children in the sample were identified with an autism spectrum disorder. The rest had other disabilities or diagnoses, all had a cognitive impairment, all had intellectual delay. A good number, 50 to 60%, had high behavior problems on the child behavior checklist. Many of them had siblings, and interestingly, about half of the siblings were reported to have learning or behavior problems themselves. So another ongoing research idea and clinical application, and this sort of relates to the sibling work, is if we're treating the family, if we're focusing on parents with respect to the target child with a developmental disability, the one with the disorder or disability, does that have implications for siblings? If our siblings are also experiencing problems, can we get more bang for our buck, so to speak, if we focus on the parents because the parents are parenting more than one child? That's an empirical question, and it's a study that one of my PhD students and I are focusing on in terms of siblings, what we can do to support siblings. And there's lots of ways we can support siblings, focus on them themselves, focus with parents, maybe have a parent training intervention that might generalize to more than one child in the home. And again, that type of work hasn't really been done much. So I'm pleased to see your focus on siblings here. This graph shows the percentage of intervals. So these are the observations, percentage of 30-second intervals in which parents were engaging in one of the behaviors that we coded as negative or inappropriate. And again, it's not a judgment. Parents are doing the best job that they can. We're focusing on behaviors that are specific to the intervention targets. So behaviors that we wanted parents to change, we were coding those, observing them both before and after the intervention. The yellow bar here is the control group. We see both pre and post intervention. The control parents are performing about the same. Our intervention, our treatment parents had a dramatic and statistically significant and clinically significant reduction in the percentage of observed intervals of these inappropriate or negative parent-child interactions. When I'm having a bad day, I like to look at this graph because I haven't had another study where we have findings that are that marked, that significant. So I have this on my phone and I can look. I'm just kidding. I don't, but I should. We see another strong finding for child behavior problems. These are not observed behaviors, although we have that too, and there is a significant reduction. This is actually parent reports of their child's behavior. we noted that in our observations, children actually had very low levels of problem behavior. And it could be because they knew they were being taped, we were videotaping. But we also told parents to play with their children. So that in and of itself was a positive activity for most of the children and families. So we didn't see a high rate of problem behavior when we observed. So we used a parent report of behavior problems. So we asked parents to fill out the child behavior checklist. And we see relative to our control kids in the yellow, our treatment kids were reported to have significant reductions in this measure of child behavior checklist. These are T-scores. So 50, which is down here, that's average. 60 is one standard deviation above the mean. And so both groups started almost 1.5 standard deviations above the mean. So that's in our clinically significant range. And then post-intervention, our treatment kids were in the normal range. Again, this is pre-post, so we don't know if this generalizes to other settings. We don't know if it maintains over time. This is just a snapshot of what we're seeing. The children with autism responded exactly the same as the children without autism. In the United States, I was telling these guys that I had dinner with last night that many families are getting a diagnosis of autism spectrum disorder for their sons or daughters, and we see an increased prevalence, more identification of this, potentially due to all sorts of things. I won't go on and on. Political reasons, access to interventions, and so on. So when I was publishing these findings, a reviewer asked me to delve deeper into the response of the children with autism versus other developmental delays and disabilities. And fortunately, the children and families who had a diagnosis of ASD looked exactly the same. No differential treatment by diagnosis interaction. I'll talk a little bit more about the Webster-Stratton intervention after lunch, but we invite parents to bring someone with them to the groups, and it could be a spouse, another family member, maybe the parent's mother or father, grandparent, or a neighbor, whoever. And parents sometimes choose to bring a support person and sometimes they don't. We provide childcare, so if both parents in the home want to attend, we have childcare provided. And I was interested in looking at whether or not the presence of a support person mattered for the outcomes. And what we found is that parents who attended the group sessions with someone, spouse or another support person, had let me reframe it so I'm consistent with the slide. Parents who didn't bring a support person reported more negative impact of their child on their family and had lower child positive impact following intervention. It's an interesting finding. We certainly don't know what that means. Maybe families in which a support person wasn't available were worse off to begin with in some way, were more stressed or more compromised to begin with. But it's just an interesting consideration when we're working on supporting parents, thinking about who brings a support person and who doesn't. Is that something we want to encourage? Is the social support, the availability of social support, a target of intervention in and of itself? Okay, do I have to stop 5 minutes? 5 minutes? I just got here. Okay, I'm going to skip this. I'll show you my fancy PowerPoint. It took me forever. Actually, I had a graduate student help me. I'm not that smart. One of the things that we're working on in terms of our research is a large-scale uptake of this intervention. So it's great when we work with small numbers of families in a rigorous research design and we get positive, statistically significant results and we publish them in journals. That's great. But really what we want to do is have interventions that can be implemented on a broader scale. Not everyone is going to participate or attend or even desire to attend a group. We know this. Sometimes group participation is low. It takes a very special person to participate in a group, right? So one of the things that I'm thinking about now, and have written about it and we're collecting some data on currently, is using more of a public health model where we have universal supports offered to everyone who might be vulnerable or at risk. And here, what I've done in my own research, I don't think is actually the best. And it'd be fun to have conversations with you all. But we offer self-administered, like self-help materials. Here's some reading materials. Here's some CDs or DVDs with strategies to promote optimal child developmental outcomes and reduce problem behaviors. Now, not everyone will be savvy enough or high functioning enough to read the materials or to watch the DVDs or to listen to the audio CDs and incorporate those strategies and do them. But from a cost effectiveness perspective, it's much cheaper to provide this material to everyone. For those that don't respond, maybe group training or group support is the next step up in terms of efficiency. It takes 1 or 2 clinicians to support a group. It's much cheaper than individual psychotherapy or individual work, clinical work with families. So maybe the group design or the group sessions might be the next step up. And then, of course, the third step could be more intensive work, one-on-one, more individualized. And what I've done in my own research is used video feedback. So we videotape parent-child interactions, and then we provide feedback to families based on their own videotape. And I'm getting some mediocre, lukewarm results for this approach, and I'm toying with it to determine sort of the best sequence for kind of our universal, our primary, and our secondary, and our tertiary supports. So the data here are, lukewarm, 12.5% responded to this level, 37.5% responded to this, 37.5% responded to the tier 3 kind of supports. Overall, the majority of our families reported positive outcomes, but some needed more intensive intervention. So not everyone will respond to our tier 1. Some might need more intensive interventions. Okay, I promise that this is my last slide. Okay, so what am I doing currently? Well, currently I'm here in Norway, so I'm not doing any work. I'm enjoying your lovely country. I want to go ice skating or sledding or skiing right now. But currently I'm working on a much larger randomized controlled trial that allows me to ask questions like, is this helping children? Is this helping parents over time? So this is a longitudinal study that's been funded by the National Institute of Health. We're following 200 families. We currently have about 180 recruited. We've got 200 families that we'll be following during the early childhood years. So we follow them for 2.5 years. We have 6 assessments with these families every 6 months, and we follow these children as they transition into kindergarten. In the United States, they transition to kindergarten at age 5. So we start our assessments at about 2.5 years of age. We have a control group and an intervention group, and we're able to look at generalization across settings. So do these intervention effects stick? Do they generalize to the school context? Because we know children may be more vulnerable, children with developmental delays may be more vulnerable as they enter public school. We're also able to look over time at 6-month follow-up assessments over that 2.5-year period, what parents are reporting. This is the model. We're interested in really having our treatment impact parenting. Parenting matters, and I'll tell you more about that after lunch if you don't already agree, which I'm sure everyone does. Parenting matters. We're looking at positive and negative interactions. Parenting self-efficacy, so how confident do they feel in their role as a parent with their sons and daughters with disabilities. We're looking at child developmental delay as a risk factor for problem behavior at home and school. We're also measuring adaptive behavior, communication, social skills, and daily living, so self-help skills across home and school as another outcome. And I'm looking at different contextual influences, parenting stress, maternal depression, and partner support as possible moderators, as possible variables that might influence parents' response to intervention and might buffer the effects of the intervention. So if they have more partner support, they might benefit more from treatment. If they have more depressive symptomatology, they might benefit less from treatment. And they might need additional cognitive behavioral therapy to address their own depression or what have you. But I'm exploring some of these variables that I haven't been able to fully examine in my previous smaller studies. Okay, I'm done. I'm not even going to read my conclusion slide, but I will highlight, if you can read this, we've just begun. We're at the tip of and you can't even read it. We're at the tip of the iceberg. I think that's perfect, maybe for a day like today. We've just begun this work, and we think that the findings are encouraging, but we need more research to inform our practice, and we need more practitioners to inform our research, and more parents to join our conversations about making our programs, our clinical programs, more effective and more useful for families in their own circumstances. So I'll conclude, and I apologize for being a little bit late.
Thank you.
Thanks.
Let's start with some questions. Yes, first one question from one of the video conference studio.
Great.
Yes?
Yeah, what do you mean by inappropriate parent behavior?
Good question. So that term inappropriate was based on a coding system that we developed that measured behaviors like, I'll just give you some examples. Intrusion on children's independence, so trying to do things for their child when their child was fully capable. Being very directive in a play setting, behaviors that were mapped onto the curriculum, providing reinforcement for problem behaviors. So, for example, giving a lot of positive attention when their child is having a problem behavior or a tantrum. Removing a demand when you've asked your child to do something like clean up the toys, and then the child has a problem behavior, and then parents don't follow through on the task at hand. So very specific behaviors that map onto the curriculum, so targets that we're focusing on in the intervention. And the term inappropriate behavior doesn't quite capture all of the nuances, the specifics of the behavioral code, and we combined all of those behaviors that we were coding and tracking that were based on the intervention targets into a combined index. And for lack of a better word, we called it inappropriate because they were behaviors that we were hoping to change as a function of the intervention. So this was not my opinion that the parenting was bad. It was not my opinion that the parenting was good. We could all see ourselves engaging in some of those similar behaviors, but we were coding them and totaling them and focusing on those specific behaviors because they were linked to the curriculum, the intervention targets. How did I do?
Great.
Okay.
Yeah. Is there any questions from the audience at Frambu? No?
It's another question from one of the studios.
Okay.
So I'll try to translate. It's from Norwegian. So how do you find out whether children or youth have psychological problems if they lack language? Do you have any methods to approach this? What's important to think about?
Yeah, gosh, great question. So psychological problems is a very broad domain. So we're not claiming that we can open the hood, so to speak, open the hood of the car and understand the motor. Or, look into someone's brain and understand really what's going on. But we have some clues based on behavior. So for children who lack language, just because they lack verbal communication doesn't mean that they lack ability to communicate. They're communicating in lots of different ways through their affect, their facial expressions, their gestures, their behavior. And we try to understand the goodness of fit between what the individual, the child with a disability, presents in any given context, home, school, and the difference between what they present and what those expectations are. So we're not necessarily looking at, and I'm going to use a term that hopefully folks will understand, within-person psychopathology. We're looking more environmentally about a goodness of fit between what an individual presents, their strengths, their abilities, as well as their difficulties with the expectations of that particular context. And so we're not necessarily saying this person is disordered. We're looking at this person's behavior or emotional response or behavioral presentation is a poor fit for that context. And then that gives us many, many more clues for what we can do to support that individual, support that child in that context. And so for me, it's less about diagnosing and saying that there's a psychiatric or a psychological problem. That's important, but it's really challenging to do that in a sophisticated way, in an appropriate, reliable, and valid way, when most of the tools that we have and we draw on in the fields of psychology and psychiatry are so focused on verbal communication. And so with individuals with communication impairments, developmental disabilities, what have you, it's much more difficult to do that. So we rely a lot on parent report and teacher report, as well as self-report, the individual him or herself, but it may not be self-report of language or self-report of feelings. It's self-report of their affective, their emotional expression and presentation. And a lot of my work involves observations of what they're actually doing and their behavior in those environments. So it's a really good question and a tricky, complicated situation, but we try to get as much information as we can from multiple sources, and we do a lot of observational work with an eye toward goodness of fit between what the individual presents, their behavior and their strengths and their support needs, and what the expectations are on the environment. Most of the time, we don't have good interventions to address core problems with respect to developmental disability. We can address behavior, we can address, to a certain extent, coping skills and social skills, but there's no way for us to get under the hood and tune up the engine. So we try to address environmental changes, work with support staff, work with parents, work with teachers, and of course provide some really good tools for the individual, him or herself, to work on behavior and social and adaptive skills and academic skills and so on. But we're not intervening on cognitive abilities per se or psychological problems per se. Yes?
You need a mic. Yeah.
I can hear you.
I think we'll have this last question and then we have to move on.
Okay, sure.
Yeah.
I already asked you, but there were several people who were in the discussion earlier about the maternal depressions that you were talking about. Why not the fathers? Why just the mothers and the influence?
Yeah. As a family researcher, we really struggle to include fathers in our research. And so we know a lot less about what dads go through. So I don't claim to say fathers don't experience depression. I think in the general population, men do experience depression. The reports of depression symptoms are lower. So clinical symptoms are often manifested, expressed very differently. They may be fewer verbal reports of feelings and more physical reports, or perhaps what we would call in the United States maladaptive coping, maybe a higher propensity to use substances to cope potentially with feelings of depression, or avoidant types of behaviors. So I'm not suggesting that we don't see depression in men. We often do. We see less of it. And we have fewer men, fewer fathers participating in our research studies that add to our knowledge base. So it's a really interesting point and a really important question. We also see at least in the samples that I've been working with in the United States, both clinically and in our research samples, fewer men identifying themselves as primary caregivers. And so their roles within the family may be very different. So many of the women, many of the mothers who are primary caregivers are reporting that their full-time job, and it is a job, it's just unpaid, their full-time job is staying at home, raising their children, and providing a lot of care for their son or daughter with a disability. And so their life, what it looks like day in and day out, is very different. Fewer or different networks of social support. Fathers, and again, these are sort of gender stereotypes, but based on my experience in research and clinic, fathers may often leave the house in the morning, go off to work, and have a very successful or at least different set of experiences and come home and deal with family issues separately. For many of the mothers, women in our study, that is their reality every day. And so they may feel more direct impact by virtue of their primary care role. But I think it's important for us to learn a lot more about fathers because we just don't have their involvement in the same way. And hopefully it's different here in Norway, but in the United States we struggle with getting dads, in part because they have lots of different roles outside of the family. Okay, I think I need to move on. I really appreciate your questions, and I will try to move quickly through these slides, at the same time not speak too quickly, so we can really hopefully get a better sense of what this intervention entails. So we'll be talking a little bit about some practical considerations of the intervention, the Incredible Years Parent Training Intervention. But I want to first start with some theoretical underpinnings. So really focusing on the theory behind the intervention, so we have a richer knowledge of what this intervention actually looks like. It is born out of lots of research, 25, 30 years of research, but it's also based on theory. And so just a very quick highlight of some of the theoretical underpinnings may be important and useful. I recognize that folks who are participating via video conference don't see where I'm pointing with my laser pointer, so I will try to keep that in mind as I talk. This model is Bronfenbrenner's ecological theory model. I'm not going to spend a ton of time going over this boring academic stuff, but it's important to recognize that we as individuals don't exist in a vacuum. We exist in multiple contexts, and those multiple contexts influence our development. And so you, in the center, could be the individual with a disability. And in my work, that's child. That's a child with a disability. The child is influenced by family, school, peers. Those family, school, and peers are part of a context. This part of the context is, of course, our economic system, our political system, our educational system, our government system, our religious system. And all of these larger systems, of course, influence how a disability is even discussed, whether it is a disability or whether it is a different ability, whether there are services that need to be accessed, or whether services are available, what resources are available, family values, societal values, culture, and so on. So it's just a little bit of a reminder that when we're working with parents and working with children, of course, you know this, but we're working within a larger context that can vary from family to family, community to community, cultural group, and so on. And so as an interventionist and as a family interventionist, it's a good reminder for me to recognize my own cultural bias and my own views and my own upbringing and my own country of origin and so on, because these values may be very different and may look very different for the families that we serve. So with this context, it's important to understand really where families are coming from and what their goals are. The family-centered intervention approach that Webster-Stratton's work is born out of really focuses on parents, and parents being, it doesn't have to be a biological parent, mind you. It could be any caregiver a grandparent, a grandmother, a foster parent, but somebody who has the role of providing care for a child, and within a family context. And I recognize not all children live within a family context. But a family-centered approach really focuses on parents, given their unique ability to impact children's day-to-day lives and the unique power that they have to potentially inform developmental outcomes. That doesn't mean that parents cause problems, and that doesn't mean that parents are the solutions for problems, but that means that parents or caregivers are an integral variable, an important part of whatever equation we come up with for promoting optimal child developmental outcomes. And so I'd like to arm parents with the knowledge and skills and efficacy, so fill them with confidence that they can make a difference. And they can make a difference in the lives of their child, that it's not just a disability or a disorder or a label that's causing something, but it's actually the environmental context and what we can do to support a child. And parents are a big part of that solution. So in terms of family-centered interventions, we've seen a great impact on focusing on parents and having that related to changes, optimal changes in child behavior and child skills, in parent-child relationships, all of those things that we really value. What is so unique about parent training or parent education, parent work, is that the interventions are delivered by somebody else, a parent coach or a parent trainer. I know we have some in the audience, and it's really the parent coach that is critical in imparting knowledge and providing a safe environment for supporting, being a cheerleader, a champion for those parents who are then working with their children at home. So it is not a direct therapy type of model. A parent coach or a parent trainer works with parents who then, those parents work with their children at home. And so what I like to think about are these intangible aspects of the interventionist. Anyone can lead a group, but there are some group leaders that just have that it factor. You know, the parent coaches or the parent interventionists that really motivate and challenge and support and empathize and connect with the families. Hopefully that's all of you, right? You're sort of giving the high five up front. Anyone can read a curriculum and walk parents through the steps of the intervention, but not everybody can connect and really establish that relationship. And I feel strongly that so much of what we do is based on fostering and developing and maintaining good relationships with those that we work with, including the parents that we support. Nobody studies this. Nobody studies it. I don't even know if people talk about it. But it's those intangible qualities of our parent interventionists that I think can really make a difference. In my previous work, I served as a parent coach, the parent interventionist. In my larger ongoing trials and with my role more in the science realm and less in the clinical intervention realm, I have therapists that I've hired and trained, and I review their videotapes weekly, and I see their sessions, and I see that sometimes they do it exactly like I would do it. And other times I think, oh gosh, I wouldn't have done it that way. I wouldn't have handled it that way. But of course what they've done is just fine. But it's their own way of doing it. And there hasn't been a single paper that I've come across in the literature that really looks at these differences in ability to establish rapport and those intangible qualities of relationships. And of course we know that those are very, very important. Webster-Stratton's approach, and many of you in the audience know this already, has targeted historically parents of high-risk children. And not until recently have we focused more on children with developmental disabilities. The intervention, sort of nuts and bolts, involve watching videotape vignettes. I'll show you a few samples. I should warn you, these videotape vignettes were made in the 80s and the early 90s. Some of them have been updated, but our IT support folks were helping me with the video, and somebody commented on, whoa, this is old school. It's true. Some of these videos are from 1982, and You know, I see myself there. I had those big glasses and those tube socks, and like that was me. So they're old-fashioned. They're old-fashioned, kind of outdated videos. Carolyn, Webster-Stratton, has done a nice job with updating some of them, but a large number of the videos are pretty old. That being said, the content and the message remains the same. Sometimes parents have a hard time, though, getting past the outdated piece of it, but they're focused on these videotape vignettes, discussion, collaboration, and support. She's focused on children with conduct disorder, children with oppositional defiant disorder, and just what she calls high risk, kind of high poverty, high needs kids. More recently, I and others have focused on children with developmental disabilities. So really the content of these videos is focused on reducing more conduct problems, more externalizing behavior problems. And what I mean by externalizing behavior problems are things like tantrums, non-compliance, not listening, aggression, disruption. So these kind of high impact behaviors. The curriculum doesn't really spend a lot of time focusing on more internalizing behaviors, anxiety and depression in the children. And so I think there's room for examining what an intervention might look like, a parent training intervention might look like when targeting anxiety and depression. But so far, the Webster-Stratton approach really targets more of those externalizing, acting out behaviors, and internalizing behaviors are more acting in, anxiety, depression. The intervention itself is really informed by this coercive cycle of interactions. And the coercive cycle of interactions was introduced by Jerry Patterson a long time ago. And Jerry Patterson, incidentally, was at the University of Oregon, where I am now. So I was reading about Patterson's work and citing his work in my studies for a long time. And then I moved to the University of Oregon and got to meet him. And of course I was like, oh, will you sign my article? It was really geeky. But some of his work a long time ago has really informed this approach to working with parents. So his coercive cycle of interactions focuses on really a simple interaction between a parent and a child. The parent, so in this case, the adult makes a request. Johnny, put your toys away. There's a request. The child reacts with hostility, kicks the toy, says, no, I don't have to, you can't make me. Adult reacts with hostility or withdraws. So the parent says, you better do it or else. Or withdraws and says, doesn't say anything, doesn't follow through. And the child then doesn't do what is asked and potentially gets a lot of attention for not doing it, or simply the parent withdraws the request. Ultimately, the child doesn't do it. The child is reinforced because the demand is withdrawn, and the parent is reinforced because the hostile child, the one who says no, kicks the toys, you don't have, you can't make me, the child simmers down and quiets down. So both parent and child in this scenario are reinforced ultimately, which is why this is a cycle of interactions. And so Patterson has really talked about this as a transactional, parent does something, child does something, child does something, parent does something. It's this little give and take dance. And over time can be highly problematic for any family system because the child is used to getting his or her way, and the parent doesn't feel effective at all in the role as a parent because every time they ask the child to do something, ultimately it doesn't end up happening. Sometimes it happens because parents resort to upping the ante, raising their voice, being aggressive themselves, making threats, and so on. And so it's this negative, coercive cycle of interactions that Webster-Stratton's curriculum is sort of built upon. But in the Incredible Years Parent Training series, we don't just start with focusing on limit setting and handling problem behavior, like you might think, based on the theoretical underpinnings of this work. Webster-Stratton first focuses on establishing a positive relationship with your child. And she found in her own clinical work, and some of you may agree, that noncompliance is the #1 referral source for mental health services. So child noncompliance, not listening, not following directions, the #1 referral source in the United States at least. And in order to fix that, you need to have mutual respect, you need to have a relationship built, and oftentimes parents come to the table feeling so spent, so frustrated, exasperated, and kind of with a chip on their shoulders, understandably. The child comes to the table feeling really frustrated, not heard, not supported, not listened to. And so you're really, as an interventionist, as a clinician, coming at the problem with the broken system. And so particularly in early childhood, and this may look a little bit different for older children, but particularly in early childhood, we focus first on establishing that positive relationship, building the relationship through play, through going out of our way to find the good in the child's behavior, through the use of praise, really systematically reinforcing, rewarding good behavior. And Webster-Stratton uses a great visual representation of what this looks like. She's got imagine a picture of a little piggy bank. So a little piggy bank where you would save your coins, save your money. And in this analogy, she says, you need to make sure that your piggy bank, your little bank, is full of coins so that when you need to make a withdrawal, when you need to set a limit, when you need to say no, when you need to discipline, that you've got money in the bank, so to speak, to draw on. If you're approaching discipline or managing child behavior and your bank is empty, you have nothing to draw on. So we spend many, many weeks, probably half of a 12-week session, really filling our bank, our piggy bank, with coins, with positive behaviors, focusing on play, praise, and rewards, so that when you need to set a limit as a parent, you've got money in the bank to draw on. And I like that analogy because all of our interactions with our children, or with our partners, or with our colleagues, or with our coworkers, anyone we interact with, in order to have a healthy system, you need to have about 4 positives to every 1 negative. And if you don't have that sort of 3 to 4 or 5 positives to every 1 negative, you're going to have a system that's out of balance. And so we focus so much on creating at least 4 positives to every 1 negative or corrective statement. And that's good for teaching too. So you can get lots more intervention. I didn't develop this. I want to give credit to Carolyn, Webster-Stratton, who's a good colleague of mine at the University of Washington. She's got a wonderful website. And there are materials, guess what, in Norwegian. She's translated her videos and her curriculum and made them available for a price. This stuff doesn't come cheap, unfortunately. But there are wonderful prepared curriculum that you can purchase. And you can be trained as a group leader and certified as a coach. And I recommend the process, even though there's a lot of red flags and paperwork and complications to doing it. I recommend it for folks that are seriously interested in adopting this particular intervention approach. In terms of some practical considerations, one of the things that I always struggle with is getting that optimal group size. So we talked about this a little bit at dinner last night. How big is a group? Does 2 people constitute a group? It's more than 1. Is 20 too many? Is 2 too few? And what we've found over the years is somewhere between 8 to 12. Again, it really depends on the nature of the group work. But somewhere between 8 and 12 parents in these groups seems to be ideal. Now, if everyone brings a support person, a partner, and you've got 12 parents in the group and they all bring a partner, that's 24. That's too many. We've found over the years that we don't always have perfect attendance. And so we try to recruit about 15 families, recognizing that maybe 10 will show up on any given week. If you're lucky, you can have all 15, but it's unlikely. We found for the purposes of research, we get between 50 and 75% really attending on a regular basis. Age range, so child age is also an important consideration. Having a tighter age range, I've found, is a little bit more useful than having a broad age range. If you're focusing on children and parenting, there are clear developmental differences between parenting an adolescent and parenting a preschooler. And so I found in my work, having a tighter age range helps parents identify with one another. So much of what you're doing as a group facilitator or even as a parent participant is establishing commonalities and connections within your group. And if you find that you're more different than alike, it'll be very difficult from a group facilitator, group trainer perspective to establish those meaningful connections. The beauty of a group, of course, is its efficiency. Everyone hears the same message. It's cost effective in terms of professionals delivering an intervention, but also a group can provide some natural social support, camaraderie, social support, friendships, kind of walking in your shoes type of an experience. Parents can empathize with other parents. Sometimes having a son or daughter with a disability can be incredibly isolating, particularly if you're a stay-at-home parent. This is your reality day in, day out. You have few friendships with parents who also have children with disabilities. Maybe your family has judged you, or maybe, grandparents have said, well, if you only put him in timeout, then he wouldn't, be behaving so poorly, so everyone's got an opinion because guess what? There's so many parents out in the world and everyone has this lay person's opinion about what you should and shouldn't do. And so we found that parenting, particularly parenting children with special needs, can be isolating. So bringing together groups of parents can really help in establishing those informal networks. They can also backfire if you've got the wrong configuration of groups and parents don't connect, they don't meld well together. Then as a group leader, you're working very hard to get the group on the same page and move in a single direction. So think about age range. Think about whether it would be important to have different groupings of parents based on disability. I have ideas about that. My idea is no, that we're focusing on basic parenting strategies that are universal and cut across different disability labels. But some families have different ideas about what it means to parent a child with X diagnosis. And so it's interesting. And if anyone has questions about that, I'd be happy to share my perspective. It's more my clinical perspective as opposed to my perspective as a researcher. There aren't a lot of studies that talk about the pros and cons of having different disability groupings. I think it may be important to think about developmental level of children. So if you have parents of children who are very, very high functioning but might have a disability versus parents of children who are low functioning and nonverbal and have a lot of support needs and maybe medical problems and so on, putting all of these parents together in the mix may not necessarily be advantageous. So it's important to think about optimal groupings. It's also important to think about group leaders and how many group leaders you need. Carolyn Webster-Stratton suggests 2. And my own work, we often have 3. We have 2 group leaders and we have a third person that's a go-to person that pops back and forth between the parent room and the children's room. And that third person can set up food, we provide dinner, we usually order pizza, so can wait for the pizza delivery guy, and pick that up and set up all of the food spread. The third person also is a note taker. So in my research, we take copious notes. We also videotape every single session. So that third person is not an active group leader, but is more of the logistics person. She or he operates the video camera, responds to any additional kind of need. And so we found in my own work that 3 is a pretty good number. If you only have 4 parents attend your group, please do not have 3 group facilitators. You don't want to have a 1-to-1, professional to parent ratio, because that sort of defeats the purpose. Parents might feel outnumbered, and also it's not efficient anymore. We've sort of taken out the cost efficiency part of it. The curriculum, like I said, is available at this website, www.incredibleyears.com. We provide a lot of participant materials. So when you go and you order your materials from the Incredible Years, you'll get all of the handouts that you'll need. I've actually created some modifications of materials based on my work with families with disabilities. I'd be happy to share those modifications. We're in the process, as I said, of conducting a large-scale randomized clinical trial. Following the conclusion of that trial, I hope to publish and make available all of the modifications that I've made. In the interim, I'm happy to share any of this for free, no charge. I'm not going to get rich off of this. I'm a scientist practitioner. I'm a clinician researcher trying to find ways to support the families that we're working with. You'll have to pay, though, when you go here. I'm not in competition. I'm just providing some supplemental materials that supplement Carolyn's core curriculum, which is excellent, by the way. So each participant in my projects, each participant gets a folder with agendas, the schedule for every session. We typically hold our sessions in the evening. They don't have to be in the evening. Each participant fills out an evaluation every week as a way to give us feedback about the session, what they liked, what they didn't like. It's a good form of communication. So we understand what the parents are experiencing. Sometimes they won't tell you, but they'll write it. They get a book or an audio CD that provides the material, sort of homework assignments. And then every week, or almost every week, they get materials that get sent home for homework activities. We've struggled with having parents complete their homework activities. And basically it's just a homework suggestion. If parents want to complete it, great. We haven't had particular luck. Every week we assign, I got 10 minutes, holy cow. Every week we assign buddies. And so the buddies group members contact each other and check in. We say buddy calls. It could be buddy texts. It could be buddy Facebook. It could be buddy whatever, buddy email. We provide childcare. One of the things that group leaders will need to think about is what you do if parents miss a session. Ideally, we provide interventionist support at home. So we'll go to parents' home or do a phone call and provide missed content and send things home. And we do that in our research work because we want to make sure that everyone gets the content. And we also will consider having class reunions. So at the end of our 12-week sessions, people really develop those relationships. They like it. They wish that they can continue their group participation for another 12 weeks. And of course, we're exhausted by that time. And we say, no, we're done. But we sort of put it on the families to organize a class reunion that they can participate in. I'm going to really go quickly through some of these other slides, recognizing that you have handouts, and you can go to the website, the Incredible Years website, and read much more about the curriculum. I've included it in this PowerPoint, but we won't cover all of it. It's important for group leaders to really set the tone, talk about the ground rules and expectations, and this is just good practice for any group that you're running. I'd like to highlight some modifications that I've made to the curriculum that you won't find on the Incredible Years website. And I'd like to spend the majority of our remaining time, which is probably 8 minutes at this point, kind of talking about what those modifications are, recognizing that for the motivated, interested person, you can go to the website and learn more about the Incredible Years curriculum. One of the challenges that I've faced with the Incredible Years curriculum is the video vignettes are of typically developing kids interacting with their parents. There aren't videos of children with disabilities. And so that's a problem. And actually my next research project will involve putting together a suite of videos, of DVDs that involve, and this is a Frambu project, actually, you should do this. We should do this together tomorrow. Putting together a suite of videos of parents interacting with their children, and the children have special needs. And so in the Incredible Years series, these are typically developing kids. It's sometimes a bit of a turnoff to parents who are watching these highly verbal children on video. So as part of the modifications, we have really highlighted the child's developmental level. And so we'll watch a video, and then we'll think about what considerations do we need to think about when working with our own children at home? Language differences, communication abilities, behavior, and so on. So there's a lot of on-the-spot contextualizing because it won't automatically transfer. The parenting principles are the same, but the developmental level is really important. Another emphasis that I've placed on the modifications that I've made is a focus on the child's strengths and the child's assets. A child with a disability is just a child with differences, strengths and difficulties, just like any of us. And so really getting parents to think less about the disability and more about, who your child is and what are their strengths, what are their assets, what strengths do they bring to the table. We're all human beings. At the end of the day, we all have strengths and difficulties. And so really focusing on that has been something I've learned over the years. I have, for the purposes of my modifications, omitted the section in the curriculum that focuses on timeout as a behavior strategy. I've done that for a variety of reasons. I don't have time to tell you all about my rationale for that, but I'd be happy to talk to you more about why I have omitted timeout. And what I've done instead in this curriculum is introduce this notion of functional behavioral assessment. And so getting parents to really work with the clinicians to identify the function of a challenging behavior and use a framework for doing so. And then I've also included a segment on collaboration with special education and medical teams. So these are all pieces to the Incredible Years curriculum that I've added, so modifications that I've made. The Incredible Years curriculum is great. I've expanded on it. I'm not going to go over everything here, but this is basically a lesson plan for the 12 weeks. And the sections that I've highlighted are the new content, the new lessons that I've added as a function of the modifications I've made for supporting families with children with disabilities. And so many of the aspects of the core curriculum remain, and I've made some additions and some enhancements. This is available in a published study, and if anyone wants to talk to me more about this, I'm happy to provide additional information. A typical session is like this: welcome, review of the home activity, introducing the new topic. There's a nice brainstorming section where once you introduce a new topic, you sort of brainstorm benefits and barriers to using that strategy. And then you watch some videos, you talk about it, you wrap up, they fill out an evaluation, and you have and you go home. Every week, we provide an outline in the packet that parents have in their folder that goes over the game plan, the outline for that evening. And I've just highlighted some of these aspects. The next set of slides really talks in great detail about the content for some of the core curricular areas. And in the interest of time, I'm not going to spend a lot of time going over the content. Suffice to say that these are evidence-based strategies for promoting positive child developmental outcomes. So focusing on playing with your children, and there's 2 weeks that we spend focusing on play. And using strategies, I'll just highlight 2. Following your child's lead. So much of the time when we play, especially playing with our children with disabilities, we do everything for them. Do this, do that. It's not play. It's not child-directed. It's parents directing or not playing because they sit back, they don't know what to do. The other thing we focus on is decreasing the number of questions that we ask, and instead using a strategy called descriptive commenting. And we found, and this is actually unpublished research that I'm working with a student on right now, we found through videotaped observations that when parents ask fewer questions and simply describe what it is that their child is doing in play, we see corresponding an increase in children's language. So instead of saying, what color is that pen? What is that? Put the water over here. What is this? What color is this? What shape is this? Lots of academic types of things. When you simply comment, oh, you've got an orange pen, or you're building a tower, you've got a blue block, this is a square. When you simply comment, you see children engage a lot more, and boom, their language comes out even more. And we've just noticed this anecdotally with the videotapes that we've been coding, but it's an interesting reminder, and I tell parents this: when you stop asking questions and directing, your child may actually talk even more. So it's kind of encouraging.
When a young child is playing,
now, you're not going to be able to hear this, which is annoying. I understand that the participants who are participating remotely can hear. Wanted to show you just a couple of, how much time do I have? None. 2 minutes. Oh, okay. This is poorly planned. I just have so much to say. So anyway, this is an example of a vignette that is describing a parent's pacing too fast. So pacing is how quickly a parent kind of directs the play, leads the play, and it's really important for our children with developmental differences to go at their own pace. And so here's a parent interacting with her child, having her child do things way too fast, and the child can't keep up. And it's sort of a humorous example because most parents would watch this. You can't hear it, so it's not humorous to you. But most parents would watch this and say, oh, yeah, that's silly. She's going really fast, and the child is not keeping up. The child is so good-natured, but it just doesn't really work. So the videotape vignettes are examples of sort of what to do as well as what not to do. You're chuckling because it's the old-fashioned, yeah, I know, it's terrible, right? Get some updated hairdos, people. There's some similar content for praise, similar content for rewards. I will tell you that the curriculum that Webster-Stratton has published for the use of tangible reward systems, is typically too far advanced for our young learners and our learners with developmental disabilities. And so I've done a lot of tailoring with this content. So for example, rather than having an elaborate sticker chart or reward system, we use very small, tangible, immediate rewards. We use a lot of pictures to demonstrate when you do this, this is what you get. And so we have to tailor it a lot for the child's individual, developmental levels. And I'd be happy to talk to you more about how we tailor this content. The content that is new, brand new to the modifications that I've made, really has to do with this focus on understanding why a problem behavior continues to occur over and over again. Webster-Stratton's curriculum really operates on the assumption that children misbehave to get attention. And I just don't think that that's always the case, particularly for our children with developmental disabilities. There may be a number of reasons why they are engaging in a problem behavior or misbehaving. So using a functional behavioral perspective really allows us to systematically answer the question through the use of data. In what context is the behavior occurring? What does the behavior look like? And what happens following the occurrence of the problem behavior, to give us clues as to how we can better support that child's need. And so the perspective is really asking, why is this behavior occurring? Not why does it happen 1 or 2 times, because if it happens 1 or 2 times, it's probably not a problem. But why does it continue to happen? If it continues to happen based on the principles of behaviorism, then that behavior is getting reinforced. And so we need to figure out what the reinforcement is. What is the behavior communicating? Because there is a form of communication in our problem behavior. There's some need that is being met. And so our goal is to figure out what the child is getting or what the child is getting out of as a function of this behavior. So we spend several weeks teaching parents how to become problem solvers and collect information about what occurs beforehand. And so we call these antecedents, and we give them a chart, and you have it in your packet. And I'd be happy to email, or I could give it to you and you can share it. Email our data collection sheets. Parents do collect data. Data is a 4-letter word, come to find out. They don't like it, but they do. And having good information, good records of when behaviors occur and under what circumstances is extremely helpful for putting a plan into place. And so we ask them, we call this the ABCs, antecedents, behaviors, and consequences. Antecedents are things that occur before the behavior. So like who's present, what are they doing, where are they, and when. When does that happen? Who, what, where, and when. And so we have parents record under this antecedent condition column, what's the circumstance before the behavior occurs? And then when the behavior occurs, what happened? What's the behavior? And then what's the consequence? And the consequence here is anything that follows the occurrence of the behavior. So I just have a little example. Home with mother and baby brother. Mother in kitchen, children playing in living room. What happened? Child hit brother. This is an example from my own life, probably. What happened? Brother cried, mother scolded child. Okay? So we need a lot more information to figure out what the function of the behavior is. But if mom is busy and when the child hits the brother, mom comes out and scolds and provides attention, then that may give us clues as to how to prevent that from occurring. Mom can provide attention on the front end. Mom can redirect and not provide attention when the child hits and do much more on the front end and systematically reinforce different behaviors. It's complicated and I fear that I'm out of time, but we teach parents an approach that is systematic for collecting information and then using that information that they bring back with our clinical team to then put individualized behavior plans in place. Okay. Aha. In conclusion, so I fear that I've sort of skipped through several of these important areas. The modifications that I've made really supplement the core curriculum, the Incredible Years curriculum. We're preserving those core features, focusing on developmentally appropriate play, using behavioral principles, reinforcing positive behavior, shifting our attention away from those more negative behaviors, teaching parents to identify potentially what the problem behavior is communicating, what the function of the behavior is. That often is a very new skill set for our parents that can be empowering because it gives them very applicable, sort of ready to translate tools and strategies for managing problematic behaviors. And they work with us as partners, the clinical team, and we deliver these interventions in group settings. There's a growing literature that suggests that these parent training groups can be effective for all sorts of parents, but really growing literature that this can be effective with parents who have children with disabilities, can decrease their stress, improve children's behaviors, and increase the number of positive parent-child interactions that we see. It can be used with very young children. It's most researched with early childhood, I would say 3 to 8 years of age. In my own work, I do it at preschool age, 3 to 5. But more work needs to be done in terms of how we can have a nice uptake in communities. We need highly trained, skilled clinicians to implement. We need motivated families to participate. And we need research to document what works and what doesn't work. And I think this last point is more work needs to be done to determine who benefits most from this and why, and what to do with those who do not benefit from this. So fully 1/3 of participants in Webster-Stratton study don't benefit. And there's a growing number of families that I work with who don't benefit because they don't show up, or they're in crisis, or they have so many needs that a group-based intervention is actually not appropriate. So more work needs to be done to determine the mechanisms for why this works and for whom. Who does this work best for, and where do we need to direct other resources for families that don't benefit? Okay, I'm done. This is an acknowledgement slide. I've been well funded by the U.S. government to do this work. I have many, many wonderful partners, medical and educational partners, a ton of amazing, awesome graduate students, and family and child participants who have offered their time, have been willing to be involved in research. And of course, my family, I learn from them on a day-to-day basis, and poof, that's humbling. So, okay, I'll stop. Sorry. Okay. Do we do questions
Thank
or
you.
no time for
I
questions?
don't think we have time
Okay.
for questions, but what we're going to do, just stay here,
Oh.
is that all the people in the video conference studios, please just send questions, and we'll send them to you.
Oh.
You can answer.
Great. Okay.
Or we can take them during the break.
Yeah.
Well, luckily, Christer is going to have a conversation with you, which is going to be videotaped, so you can go on to our web pages later on and look at that conversation.
Great. How's
So
my
you can
hair
learn
and makeup
even more
for the video?
Great. And then you're going to get this, which is made by Aurora. Christer, I need help. It's a workplace for artists with and without disabilities. Yeah.
Thank you. Thank you so much. Oh, it's
And
beautiful.
thank you for your
Thank you.
inspiration. Yes,
Thank you. It's been lovely. Thank you for inviting me.
Oh, you're
It's an
welcome.
honor. Thank you.